I was just going to go straight in.
Oh,
Yeah.
well, you can if you want, but I'll just give a quick introduction. I think a lot of you already know Adele. She did her PhD here in psychology and worked as a postdoc for a while, and then she's sort of moved, and now a year and a half ago, she just said, to Surgo Ventures, and she's working as a senior research scientist there. And I think you're going to talk to us a bit about that today and sort of about moving to industry. Um, don't all leave TARG, is what I'm going to say. But thanks. I'll hand it over to you, Adele.
Great. Thanks, Zoe. Yeah, thanks very much for inviting me here for a talk. And yeah, it's nice to see some familiar faces here. And thanks to everyone for coming and listening to this talk. Today I'm just going to talk about kind of my career through academia and my move into industry. And basically like tell you a bit about what I do now as a research scientist at Surgo Ventures, and then give you kind of some insights into my experience transitioning out of academia into industry. And feel free to just jump in with any questions anytime. I'm hoping that this session is going to be very much like a discussion based, and I can answer any questions that you guys have in terms of kind of like moving from academia into industry or anything else. So just a really quick summary of kind of like my career progression so far. So I did an undergraduate in natural sciences, specializing in experimental psychology. Following that, I did an internship in child development, and then I moved into my PhD, which was, as Zoe said, in psychology in Bristol and also in the IUU as well. And within my PhD, I was interested in looking at well-being within a policy relevant framework. So I was always interested in how we can use research for impactful policy development. So I did a lot of internships with the Department of Health, and I also worked a lot with civil servants during my PhD, and that continued on into my postdoc as well. So my postdoc was basically like an extension of my PhD, with the exception that I actually moved from psychology, epidemiology into the Department of Economics. But I was also looking at very similar things. So looking at the genetic and environmental contributions to mental well-being, again, with the kind of policy relevance in mind as well. So I did my postdoc for about 2 years. And then towards the end of my second year of my postdoc, I was kind of starting to think about whether, I wanted to continue along academia, or if perhaps I was more interested in leaving academia and trying out different roles, so within industry. And I really didn't have that much of an idea as to what kind of jobs I could do outside of academia. I knew I had a lot of these skills, for example, like coding in R, working with external stakeholders. I had kind of like developed these skills, and I didn't know how that would fit within a non-academic role. And the kind of reason why I wanted to look at these other roles was also because I was really interested in research and innovative thinking and applying like rigorous methods. But I didn't really enjoy the kind of working alone by yourself, not working often you're not working within like a bigger team. And I really wanted to kind of try being in like a bigger team and having a role within a team. So I found Surgo Ventures, and they were looking for a senior research scientist. And so I applied and was fortunate enough to get it. And so, I'm going to kind of talk to you about what Surgo Ventures does, and then kind of my role at Surgo Ventures. And so Surgo Ventures is an analytics company, and we are interested in applying behavior science, data science, and AI to kind of come up with these precision solutions to public health and population health. So we're quite a small team of about 25 people, and Surgo Ventures is based in DC, and a lot of the work is based on kind of public health within the US setting. But Surgo Ventures has also done a lot of work in terms of international development. So we've done work looking at tuberculosis in India. We've looked at maternal health in Africa, and a lot of work to do with COVID as well. So in just to kind of general overview of the kind of structure and the kind of people that work at Surgo. So Surgo Ventures is got kind of PhD graduates or master's graduates or data scientists who kind of work as research scientists and senior research scientists. And they're involved in the kind of analysis and data collection and evaluation of programs. And then on the other side of this, which is kind of different to academia, is that we have these program managers. And program managers are involved in kind of the end-to-end management of the entire initiative. So they're involved in, working with stakeholders, presenting to stakeholders, getting new partners, and also like dealing with timelines and like deadlines for different people within the team as well. So a little bit more about kind of my role as a senior research scientist. So I provide research knowledge and technical expertise to projects. I'm involved in kind of applying that research knowledge to develop innovative project ideas and proposals. And then I'm also kind of responsible for maintaining the rigor of our analytical methods. So one of the things that we at Surgo Ventures really want to do is that, we're not in academia, but we still want to maintain the scientific rigor of our work to the standard as is kind of like typical in academia. On the day-to-day basis, I typically am involved in doing literature reviews. I do data collection and analysis and data processing. I'm also involved in creating presentations to internal meetings and also to external stakeholders. And then I'm also involved in writing proposals or reports of our programs, or in writing manuscripts, which we submit to academic journals for peer review. So I work very closely with program managers in terms of negotiating timelines. Often program managers want like a certain result within a certain date, and usually that's not very attainable from a kind of data analysis perspective. So it's very much like negotiating timelines with them. We also work very heavily with a communications team to visualize our results and our work. And this is like a strong strength of our kind of like work in general, is that we work really hard in creating these appealing and publicly engaging visuals for disseminating our work. And then I also work on leading research scientists and analysts in kind of our day-to-day data analysis and kind of general research work. So now that I've kind of talked to you about kind of my day-to-day work and also the work that Surgo generally does, I wanted to discuss 2 examples of the projects that I've been on to give you an idea of the kind of work that we do, and also the what kind of goes into creating these projects and what exactly we do in these projects. So the first thing that I'm going to talk about is a project looking at mental health care seeking intention in the UK. So Surgo Ventures has done a lot of work in terms of maternal health and COVID, but we've done less work in mental health. And that's something that we really want to branch into, because we know that mental health is kind of like the hidden pandemic. And as we all know here, and it's something that we all need to do more in terms of research and getting good data for. So in my PhD, I looked a lot into mental well-being and kind of the causes of mental well-being, the interventions that we could do in terms of treating mental health, or people could do to improve their mental health individually. But one of the things I actually wasn't that familiar with was the kind of service provision side. And that's actually like, a huge part in terms of people having mental illnesses and going to seek care. And there are lots of gaps and kind of under-resourcing issues within service provisioning of mental health care, as we all know. So, the NHS is really under-resourced in terms of providing care of any sort, but especially for mental health care. There's huge wait times. There's a lack of service providers in terms of therapists or other people that provide these mental health treatments. So that is like a huge issue, but then there's almost like another huge issue that is not as well covered and is not as well researched. And that's actually this side of like intention, this mental health care seeking intention side. So there are people that are, realizing that they have a mental illness and trying to seek care, and they're unable to get it because of under-resourcing issues. But then there are all these people that might not even know that they're dealing with mental health issues. And so they don't even have the intention to go seek it. And there are these people that know that they're dealing with mental health issues, but they have barriers in terms of stigma. They don't want to go to a service provider because they don't trust treatments. And then there are also barriers in terms of structural barriers like costs or transport and childcare issues and things like that. And so we wanted to kind of delve into this intention side of things to look into basically what are the levels of intention in the UK? How are the levels of intention distributed across the UK into geographically granular areas? And what are the key kind of perceptual and contextual drivers of care-seeking intention? And there has been some research that has looked into this in the past, but we felt that the research and the kind of surveys that have been done to look into this are outdated, and they're not completely comprehensive, and they're not completely geographically granular. And so we conducted a community mental health survey that has this like geographical granularity and comprehensiveness, with the aim that we'll be able to help local health leaders to address the growing mental health crisis. So the objectives of this project was that we wanted to highlight inequity in mental health care needs and access across the UK. We wanted to, as I said, uncover these barriers and the issues that are hindering timely access to care. We wanted to supplement NHS data. So when you go on to look for data in terms of referrals, bed times, waiting times, we're actually provided with quite rich data at the NHS level through kind of like NHS services. So we have that data available, but then there's this unseen, unaddressed side of perceptions, which is less commonly measured. And so we wanted to supplement the NHS data in that way. And then we wanted ultimately to be able to kind of help leaders of society and health systems to develop actionable solutions. So in addition to kind of asking about perceptions and contextual barriers, we also asked whether people were open to different forms of mental health treatments and what were the most likely channels through which they would access support, to kind of get an insight into what are the channels that we can really most easily kind of affect change and cause people to seek care in a kind of more easily accessible way. So to do this, we ran a survey of 17,000 people. And as I kind of have been mentioning throughout, I've said that we really wanted this geographical granularity. And typically surveys tend to be focused in England, they tend to be focused in cities, and they don't have adequate coverage across the entirety of the UK. And so we're not able to, use traditional surveys and the insights that we get from traditional surveys to give direct actionable solutions to each of these local health leaders beyond, like London or Manchester or the key cities. And so we really took a lot of efforts to try to get adequate coverage and ensure that we were able to get respondents from each of the 179 ITL3 regions. And they're displayed here. So basically it's just coverage across the entirety of the UK in these small areas. When we were able to collect this data, we also conducted rigorous data processing methodologies in terms of applying weighting structures to make sure that the data was nationally representative and also representative to the level of the 3 nations as well as the 9 regions in England. And we worked really closely with London School of Hygiene and Tropical Medicine and King's College London to ensure that our methods of data collection were rigorous. And also we were collecting the right measures using validated scales as well. And so basically this led to us developing the most comprehensive and geographically granular community mental health care survey in the UK. And using the results from the data that we had, we were able to kind of project estimates to the level of health boards. So there are 64 health boards across the whole of the UK, and we were able to basically use our results with enough accuracy to produce estimates for 61 out of 64 of these health boards. We weren't able to kind of give estimates for 3 health boards for the kind of outer Scottish Isles because we just didn't get enough participants. But for the rest of the health boards, we were able to kind of get robust data for that. And just a kind of summary of the scales that we included into our survey. So we very much wanted to incorporate validated scales that assess different aspects of drivers and perceptual barriers to mental health care seeking intention. And we selected these scales based on a comprehensive review of the literature to identify that there were these 4 overall things that tend to influence care seeking intention. And that's knowledge, attitudes, behaviors, and barriers. And in addition to that, we also incorporated demographic variables, as well as well-being and mental health correlates and control variables. And then also, as I mentioned before, we asked about support channels and the preferred modes of service delivery for people as well to get more of an insight into the actionable solutions that we could do. And yeah, so this was these scales were very much influenced by our discussions with King's College London, the Indigo Network, and also were in line with other assessments as well. So for example, we used the similar demographics as is captured by the census and also by service evaluations of programs like the Time to Change program. And once we collected the data, we were able to process it and analyze it. And so we ran through the typical data analysis kind of pipeline of doing the data processing, do the exploratory data analysis, followed by doing predictive modeling. Once we have those insights, as I said before, we really have a strong emphasis in how we communicate these insights in an appealing way to the public, to health leaders, and to anyone else that's interested in kind of consuming the data or understanding what we find from the data. And so what we work really strongly on are the data visualization aspects. And so we created this website that visually represented the data that we collected and analyzed, which is basically this like mental health data explorer, where we investigate why people are not seeking care. And we call these people those that are suffering silently with mental illnesses. So continue. So we were able to basically map out these different indicators of need, of reluctance, and also of barriers to care because of the fact that we were really aiming for geographical granularity in our survey. So we were able to kind of project these estimates of the percentage of people who had mental health difficulties, percentage of people who had possible depression or anxiety as assessed from the PHQ-2 and GAD-2. We were also able to look at levels of prevalence in terms of the reluctance to seek care, those that wanted to delay care seeking, or those that just had gaps in their knowledge of mental health. And then we also mapped things like things that were the drivers of care seeking intention or the barriers to care. So things like stigma, attitudes towards treatments of mental illnesses, and then also like logistical challenges like cost or transport. And so in order to make it actionable and easy to use for health leaders, we mapped it out to the level of these health boards. And so if you're a health leader or if you're a member of a certain health board, you're able to search for your health board based on your postcode. So so I searched for Bristol. And you're able to kind of see where Bristol Health Board or integrated care system lies with respect to the UK average, with respect to all the other health boards in the UK. And you're also able to compare other health boards. So we're able to compare the level of local need in Bristol compared to Bath Health Board, just to see how each health board are doing relative to others as well. And then following on from that, we go into an even deeper dive into each of the health boards. So as I said, our survey was really comprehensive, and we don't even share all the data that we have collected in this, but we really go into the specifics. So in the kind of summary maps, we had a map of possible depression and anxiety, but then we are able to break it down specifically to depression or anxiety. We're able to actually identify what are the top barriers that people reported within the three categories. So for example, in the kind of stigma category of barriers, 18% was the highest in Bristol of people who said that they felt that being embarrassed or ashamed was like a major barrier to stopping them from accessing care. And then we go on to kind of talk about the channels and the different ways in which people are likely to access care, through kind of self-help materials or through talking to a mental health professional. So if there are no questions, there's a comment. If there are no questions about kind of that project, I'm going to move on to talking about Rise for Moms, which is another project.
Next question, please, Adele.
Yeah.
It's a super interesting project. My PhD was in geography, and I did a lot of stuff on how where you live affects your mental health and that kind of stuff. And love pretty maps. A really good job on pretty maps. I feel like it's something that I have struggled with in bits in my research and in designing research. But I feel like as you said, the lack of uptake of service use in certain groups, which are going to be like systemically underrepresented for all sorts of reasons in like actual treatment uptake, is a huge issue. But I don't think that I've been like convincingly sold on how you would like be able to quantify that using a voluntary survey, because I don't know why you wouldn't just recapitulate the same things, right? Assuming there are reasons for people not engaging in a healthcare service, why do you have like strong priors on why that would be different for a voluntary survey?
Sorry, could you repeat that question? So what do you find unconvincing?
So I guess if you know that people are going to be less likely to participate in or to engage with healthcare services, maybe I misunderstood at the start that part of this is on understanding why that might be the case, or what are the barriers to people participating in a healthcare service. Why do you think that using a voluntary survey, which presumably is going to have the same kind of factors affecting whether people participate or not, why do you think it's likely that you'll be able to infer about the reasons for non-participation using a study that is necessarily voluntary participation?
Yeah, that's a really good question. I think there are limitations in that, it's a survey there, whether it's voluntary or it's or whether it's a probability survey or non-probability survey, you're always going to get biases in terms of response. So there are issues of not capturing the right kind of people. But I do feel like these are kind of two different behaviors that you're talking about. So survey participation, I think, is very different to access of mental health care for a mental health need. I think I'd say one of the really strong barriers that come out are costs and structural barriers, and that's not going to be a barrier that is impactful for participation in a survey. And I guess we ask the questions specifically to what would stop you from accessing care. And so they would say like stigma would stop me from accessing care, but that doesn't necessarily mean that stigma would stop them from participating in a survey, I wouldn't think. But yeah, I definitely agree that, there are some there could be other ways that we could capture this, and that would give us another form of information. And obviously the ideal scenario would be that, you know, we collect information from a survey, we perhaps do like some other sort of data collection and kind of triangulate the results to kind of get the true investigation of it. But the fact that overall in the survey, we find that around 20% of people were reporting that they wouldn't access care if they were experiencing mental health difficulty. So that's still like a significant proportion of people. And if we were to say that, you know, people who aren't accessing care aren't responding to the survey, then we would expect this percentage to be a lot less. So I think there's still, you know, we do still find interesting insights, but we can still find additional insights through other forms of data collection.
Yeah, it's super interesting. I think it's a good point that they're likely to be different, but that you say it's a triangulation question probably more than a like, can you nail it in one survey design?
Yeah.
Actually, put in a fellowship application to try and look at like designing a study that would allow you to look at the reasons for participation. But I think basically having spent forever doing selection bias methods and weird geographical stuff, I think the only answer to that really is the qualitative stuff. But I'm not really certain how. Yeah, it's not necessarily going to be scalable unless you find people who aren't going to participate and go and ask them specifically why they won't, I think.
Yeah,
I'd be really interested to chat to you about it afterwards.
Yeah,
definitely.
I feel like
I'm taking up forever in this conversation.
No, it's fine. I'll definitely be able to chat to you about this because we have also been thinking about alternative ways of data collection beyond survey. So yeah, it'll be interesting to talk to you about it.
Yeah, that'd be super interesting. All right, sorry, I'll shut up. There's another question.
I see Helen has a question.
Yeah, there are people in the chat as well, but I maybe have my hand up first, so I'm going to go. So my background is I'm a child and adolescent psychiatrist, and so I guess that I have a kind of health services bias. But I was just wondering, because it does sound like a really interesting thing to have tried to understand, whether you were kind of asking people about their willingness to approach their GP or their potential willingness to be seen within secondary care services like by a psychiatrist or a psychologist. Because I guess when I think about barriers to treatment, I think, you know, there's kind of within self barriers, but then there are also potentially within system barriers, like you go to your GP and they don't refer you on, or you go to your GP and then you don't feel like you can talk to them in your appointment about your mental health. So I just wondered whether you had looked at that.
So our overall kind of main outcome variable was a question where we asked if you were experiencing significant mental health difficulties that were affecting day-to-day functioning, would you seek help from a mental health professional or voluntary service? So we kind of encompassed everything, basically just capturing some way of them seeking mental health care, either through a voluntary service or through a mental health professional. So we kind of linked the barriers to that, but we did have a question at the end, as I was saying, in terms of accessing support. So what are their most trusted channels of support? So are they very likely to reach out to a mental health professional or a voluntary or community group, or perhaps through school? We did kind of capture that a little bit, and we find geographical differences in how open people are to these different forms. So overall, most people were, I think in general, it was like 60 to 80% of people across the different health boards were very likely to access a mental health professional for support. But it was really interesting because in some areas, people were more open to accessing a support team through their workplace or school. So think places like London, but then there were a lot of places that were not very open to these support teams in more rural areas.
Yeah, it's just really interesting, I guess, because I mean, I'm a child psychiatrist, so a lot of our referrals come via school and social care and things, but like in general, psychiatry, the majority of referrals come via GPs who deal with the kind of vast majority of depression and anxiety in the population. So I guess, yeah, I don't know, it kind of feels like maybe if the survey was to be redone, it should specifically ask, because it's quite hard to like directly access a mental health practitioner unless people perceive GPs as being mental health practitioners. Yeah, I don't know. Anyway, complex, interesting, really interesting about who's not seeking help when we know
I think it's
services can't meet the needs of OCD.
Yeah, I do think it's really interesting. I mean, kind of from my experience has always been through the kind of research side. So I have less experience in terms of how people go to access care, but I think it'd be really interesting to explore. We didn't look into this in very much detail, but explore their knowledge of what are the actual pathways through which you should go to. I feel like a lot of people don't know whether they should go to their GP for an issue, or they should go to, like, you know, go onto a website like Mind to get some signposting. I think that's a really interesting thing to explore.
Yeah. Cool. Very interesting. Thank you.
Right. I'll see another question.
Yeah, there's a few in
I've got a few questions.
I don't know if you want to answer them now, or if you wanted to. I don't know how much time you've got left on your presentation. I'm just conscious that it's.
Yeah, maybe I will move on to the, I don't have too many more slides, but I move on to the second project, and then I can come back to these later as well if we have more time at the end. Okay. So kind of shifting gears onto another project that I'm working on that's not to do with mental health. This is a project that I'm kind of at the start of the program evaluation side, but I wanted to give this example because it's kind of different to what we're normally used to in terms of getting a survey and analyzing the results. This is very much a program that has been created to implement change on the ground. But then also we have this like evaluation side of things that I'm kind of getting into. And so this is a program called Rise for Moms. It's to do with maternal health and maternal and infant morbidity and mortality. So this is a project that's based in DC in the US. As a kind of like whistle-stop background, basically maternal morbidity and mortality is shockingly very high in the US for such a developed country. In comparison to other developed countries. And it's an issue that occurs in all the different states of the US, and it especially occurs in these like pockets of vulnerable communities. In terms of, so in the DC, there are these high rates of infant and maternal mortality that are concentrated in areas that are usually very far away from hospitals, and they have less accessible public transport. And we know that one of the key determinants of health outcomes for mothers and children are the access and availability of timely and adequate prenatal care. And one of the kind of key barriers, so you might have noticed that we are always interested in kind of identifying these barriers to different behaviors. But with respect to maternal health and also specifically prenatal care, one of the key barriers to accessing care in the US and in DC is the lack of affordable transportation. And this is really the case, especially for low-income families and also women of color. And so Surgo Ventures partnered with Uber, as well as 2 health centers in the DC area to create this Rise for Moms program, in which we wanted to create an integrated patient-centric transport option, but also embed like a robust evaluation on whether it actually works or not. And so to go into more detail in terms of what this program involved, basically it was just giving patients free rides to and from their prenatal appointments. There were a lot of kind of intricacies in the development of this program. So in addition to just giving them free rides, you have to think about kind of like the logistical and structural barriers as well. Some people don't use Uber, don't know how to use the Uber app. Some people don't have access to smart phones that allow them to use the Uber app. And so we had 2 solutions. We were able to give patients vouchers so they could use the voucher on the app themselves, but we also integrated a care delivery system in which patients could call specific people in the health end. And so, as I said, it kind of addresses like a holistic list of barriers in terms of cost and transportation, addresses these logistical and structural barriers, and also addresses these behavioral and motivational barriers. Some people just don't have the time, or it causes them mental strain to have to like arrange these appointments themselves, in addition to like all the other things going on during their pregnancy. And just to say, like, this was the first kind of integrated ride delivery service that was developed in the DC area. And so this has been going on now for about a year and a half. We've come to the end of the data collection period, but we're continuing to give rides for free to these mothers. But just to say that early findings are really promising. We're finding that 68% reported that they originally did have difficulty in finding transportation to their appointments. The cost and unreliability of public transportation was a huge barrier. And the two different solutions, so people booking rides themselves or asking the health centers to book for them, they were serving very different people with different needs. So far, we've provided 3,000 plus rides to 400 plus participants in this program. There was very high level of enrollment, so people were very keen to take part in this program, and also usage of the rides once they were enrolled. So 41% of appointments use the program. They are also serving kind of people of color, people who are not employed, and people who are at high risk of pregnancy. We've actually found, so for example, someone who was at a really high risk of pregnancy, they ended up taking 51 rides through Rides for Moms. And then just to say that, again, this is very early data, so we're just at the start of the data processing stage. We are finding that 76% said it would have been difficult to attend rides without the program, and they have reported that it's easy, it's time-saving, and it's reliable. And I was going to say that I was going to have a slide where it kind of shows you the complexity of the data that we're kind of dealing with. But I found Rides for Moms really interesting because it's basically dealing with like real world data, and it's data that's come from these health centers. So it's data that's come from these places that don't have experience in data analysis, don't have experience in collecting data. And we have rich data in terms of like actual attendance records, what kind of appointments people were attending. We have also data from surveys from the participants of this program. And we also have data in terms of like the rides that they took, the length of time it took for people to get from one place to another, and the distance. But it's been like a huge task, kind of like QCing this data, combining these data sets together. And it's very different. It's a very new kind of project that I've been working on, and it's basically been like super interesting trying to deal with real world data. But yeah, that's just a kind of side point. And yeah, that's all I have to say on Rides for Moms at the moment, because we are still very early stages. And that's I don't know if anyone has any questions on Rides for Moms. I'll stop there. No questions. Okay, well, oh, I see one in the chat. Oh, such a good idea. Yeah, it is. So yeah, and just to say, like, Uber have been really keen on this project as well, and they've seen the kind of early findings, and that's almost been enough for them to say, we want to expand this to other states. And so there's very much like a scaling up process as well going in the background, kind of being organized by program managers. And then just the last point to kind of discuss this whole like transitioning from academia to industry. So I hope to kind of have convinced you that the work that we do at Surgo Ventures is actually very similar to what I was doing in academia. You know, we are very much into analyzing the data using easy and kind of simple as well as complex statistical methods, kind of branching out from predictive modeling to causal AI and things like that. So I really enjoyed kind of being at Surgo and kind of still using the skills that I've learned throughout my PhD and my postdoc, and using the same kind of critical analysis skills and experience and knowledge and apply that to my job now. I guess I like wrote some points here in that, I mean, we all know that like a postgraduate degree, a master's or a PhD can open many, many doors for you. I guess when I was like in the lows of my PhD, I was like, why have I done a PhD? I've like wasted all my time, 4 years of this time. But looking back, you know, it was interesting doing the PhD, but having been able to gain data analysis skills, the critical thinking skills, that's all really very much opened so many more doors in terms of jobs in industry. So don't give up hope if you're like at the lows of your PhD. There's always hope. So yeah, as I said, there are quite a lot of companies and jobs that are doing very similar work to academia. I think there are more and more jobs that want to maintain the academic rigor and also create impact. And I didn't know that there were companies like Surgo to work in before, but yeah, it's definitely something to keep in mind. If you are thinking about going into leaving academia or going into industry, or even working with partners in industry, I'd say get yourself a LinkedIn account and make that really like snazzy and jazzy. Also, like consider reaching out to people. And I was going to write network, but I know that everyone hates networking, but essentially it is kind of like networking, but it doesn't have to mean, you know, networking doesn't have to mean you go to a conference and like insert yourself into a large group of people and start talking. It can be, you know, reaching out to people via LinkedIn or emailing people. I think like that's actually something that I'm happy when people like email me or message me on LinkedIn to ask a specific question about my job or ask to like just talk about it. And that's really a good way of like finding new opportunities and expanding your network that way. And yeah, like a last point is kind of, if you're interested in going to another route, think about, you know, gaining experiences in presenting to non-academic audiences and really tightening up your your presentations to make it applicable to non-academic audiences. Think about learning things through blog posts or YouTube. I find loads of great YouTube accounts that kind of tell you about different jobs within data science. And then think about like courses online, so things like practical data science or Google data analytics. And this is kind of the data science side of things. There are like loads of other courses in terms of project management or things like that. And that's basically it. Just to say that we are hiring, so feel free to reach out to me. There's a shameless plug, but feel free to reach out to me if you are interested in joining Surgo or just learning about the work that we do. I'm very happy to talk to you guys about that. And yeah, I can go back to the questions on the mental health service uptake survey, or I can answer questions on general transition from academia to industry as well, if anyone has any questions.
Thank you, Adele. That was really, really interesting. It was great to hear examples of the sorts of things that you do as well. I don't know if you want to go back to the questions that were in the chat. I think Robbie had a couple of questions. Yeah. Robbie, I don't know if you want to ask them. I can read them out if not. But I think, are you there?
Yeah, sorry, I can read that. Can you hear me?
Yeah.
So I'm using a crappy headset in the garden. Yeah, thanks a lot for that talk. That was like super interesting. And I'm also thinking about going into industry, so for that reason as well. But yeah, in terms of the survey, like it seems like really like altruistic, really useful data. And I was wondering, because it's industry funded, whether that creates any kind of barriers in terms of like proprietary concerns with sharing the data either completely publicly or even privately, but with institutions that might benefit from it, like the NHS.
Yeah, that's a really good question. So we are, I guess so Surgo Ventures is actually a non-profit organization. So we're kind of like in the middle between like industry and academia, I guess, in a way, in that we very much want to provide our data to like the NHS or to government when they would find it useful and it would implement change. But you're right in that we don't want to completely share the data set, because that is kind of like our intellectual property. And we also don't want people to just use our data set in any way, because then we can't really regulate the standard of research that people are doing on that data set as well. But that's definitely something to consider. Sometimes you can't really share all your data set all at once because of like intellectual property issues.
So that kind of overlaps then with my second question, which is about like the sort of funding industry perspective. Like how, I guess I can see how a company that was like a for-profit company would want to monetize things and keep their data in a black box. But how does it work as a sort of a non-profit? Like if that's funding coming from like charitable organizations and stuff. Firstly, it seems like that would be something that should maybe be closer towards the publicly sharing data. And that's it really.
Yeah, so to give you a bit of background in terms of funding structure at Surgo, so we would apply for grants, kind of similar to how you'd applied for grants on like the Wellcome Trust or something. We often get funding from philanthropists. So yeah, just basically really wealthy people who really want to share their wealth in social good. And we also, so this project to do with the UK was funded by the UK government. And so they don't require us to make the data public, but I guess they require us to make the insights public, and to always share the insights. So it's never really, from my experience and from kind of knowing about the different grants that Surgo has been worked on, it's never been a requirement to share the data from the funder side. But yeah.
Okay, yeah, that's interesting. I'll pass over to other people.
Thanks, Robbie. I think Jackie, you had a question next. I'm happy to ask it unless you want to unmute. Thanks, Jackie. So Jackie's question was sort of when collecting data about barriers, was this sort of, or other options as well, was this sort of free responses, or were they kind of already coded sort of pre-decided tick boxes? So if it was the kind of pre-decided option, how did you kind of choose what those would be?
Yeah, so we collected data on buyers as well as everything else on usually like tick boxes based on validated scales that have been developed. So for example, for barriers, there is a 30-item scale called the Barriers to Access to Care Evaluation, developed by the Indigo Network at King's College London. And so we included that into our survey. But then from the literature review, we felt that there were some like barriers that were missed. So we included some additional itemed questions. But we also did include a free response text to say, are there any other barriers that we've missed out? Yeah.
Okay, that's really interesting. I was going to say, was there a free one? Did you find anything as a follow-up for me, like anything that you weren't expecting to come out of the kind of free response options?
Nothing that jumps to mind. We didn't really go that deep into the analysis of the free text responses. But nothing really jumped out. I think a lot of time, sometimes it seemed like it was almost like they were criticizing like the service provisioning side, kind of like what we were saying about earlier. Like they were saying, why would I go to access care if I'm gonna have to wait this loads of time? And people have, my previous experiences have kind of said that, have shown me that sometimes my feelings aren't considered or my experiences aren't considered. So yeah, things like that.
Okay, that's interesting. Sally, did you want to ask yours, or did I just read it out?
Yeah, I can ask it. Sorry, I haven't got my video on.
Sorry.
Okay. Yeah, so I might have read the graphs wrong, but on the map it showed like every region of Britain seems to have a 30% plus level of depression and anxiety. So if it's like 30% and above, then the NHS have said, you know, it's 1 in 4 people that will experience a mental health difficulty in their lifetime. but this obviously shows different to that, and it shows that it's higher. So I think maybe this should be informing the consensus because it's based on NHS criteria. And I just wondered if any conversations were had about that.
Yeah, that's a good point. So I'm not sure how the NHS defines it, but is it that do you know if the NHS defines it as clinical screening for depression or anxiety, or it's kind of
I'm not sure.
So our possible depression anxiety is based on the PHQ-2 and the GID-2, and they don't screen for depression or anxiety, but they are kind of precursors to the bigger PHQ-7 and GID-9, or I think I got the numbers wrong, but basically they're 2 questions. So they're they give you like some sort of indication as to whether you might have symptoms that should direct you to get evaluated. And so we really do specify that in kind of the definition, because we didn't want to say like this is the actual prevalence. These are based on like shorter measures. And so, this is an indication that these people could warrant being evaluated by a GP. So, but we do want to have these discussions with the NHS, not just to do with this, but to do with like everything else that we're showing as well.
Yeah, that makes sense. Thank you.
Thanks.
Thanks, Sally. I think Thea and Gareth had kind of questions more about your move to Surgo. I might just quickly summarize them because I feel like we're running out of time. But Thea was wondering how you sort of found the job ad for Surgo Ventures. Was it via LinkedIn? And whether there's kind of any equivalent websites to jobs.ac.uk for industry. And then Gareth is kind of related, sort of at what point in the process of leaving did you end up handing your notice? Colleagues have struggled with that a little because of the kind of 3-month notice period you have to give with academic posts. So
so I find this job on LinkedIn Jobs. I actually find LinkedIn Jobs to be better than going on jobs.ac.uk, because I find that the jobs on Jobs website they're like a whole range of different jobs, but like I don't think I would have ever found a job like Surgo Ventures on jobs.ac.uk. I think LinkedIn, maybe specifically for data science, I find it easier to find jobs around data science on LinkedIn Jobs. And then to the point about leaving, so it actually came at quite a good time for me because I was just about to start another postdoc in like a month's time. And so it wasn't great of me to kind of say I couldn't start that job. But basically I was able to hand in my notice with 1 month's notice. I think that was in my contract actually, that I only needed 1 month's notice for that job. So it wasn't too hard for me. And also this job at Surgo, they wanted someone to start like within the month. So it kind of worked out perfectly for me. But I know that is a bit of a struggle when you have to give a 3-month notice. But also, I guess other jobs, maybe you can kind of get an offer for the job and then negotiate and say that you want to start in 3 months' time. And some areas, some companies are okay with that. So yeah.
Great, thanks, Adele. I don't know, did anyone else have any other questions? Got a few minutes left.
Ask another quick question, which was, is only from having Googled it before this, because I'm not a psychologist, so I wondered if I should have absolutely known what Surgo was, because I'm an idiot. Is based in Washington?
Yeah, it's based in Washington, DC in the States. And is that like a thing that you feel like is different now that post-pandemic-y stuff, that you can apply for stuff and just be like, hey, I have no idea whether you live in Washington, but I'm gonna go on a limb and say that you don't. Yeah, I'm still in the UK. So my job is completely remote. They're quite flexible. They were very flexible at the start because they wanted someone who was working on the UK work. So they were basically looking for someone based in the UK. Surgo have a lot of people who work in different areas of the world. Like in India, we've got 2 people in the UK. We've got different people in different areas of the United States, and there are loads of like time zones there. But I do think companies are getting less open to remote work. I think I just happened to find it at a right time when everything was remote.
Yeah, okay, that's super useful. Cheers. Also, is it right if we nick an email address to you, just in case? I'm asking for a friend who's completely fucking illiterate with LinkedIn who might want to contact you after this.
Yeah, I can put my email address in the chat.
Sweet. Okay.
Thanks, Adele.
Cheers.
I have a really quick question. I just wondered how much, or if any kind of work is done with the public. You know, we do like PPI, public engagement in academia. I feel like that's getting increasingly more the case. I just wondered if there was any kind of aspect of that in Surgo or industry.
Yeah, so I haven't done any work directly with public myself, but I know that Surgo does do a lot of so at the start of a project, we would like to do like focus groups in the development of studies or like surveys. We would like to kind of reach out to people to see whether that survey would be acceptable for them. So there is a lot of work with kind of individuals of the public, and also in terms of the communication side, I think it really adds to the stories about data when we have these like personal experiences as well. And so we've also worked with like news outlets who've got personal experiences to like supplement the work that we've done in terms of data.
Okay, that's really good to hear that you have that kind of input still. Jazz had a 1 minute left. How do you find the workload compares to academia? Was Jazz's question.
Yeah. Okay. So I feel like everyone's experiences in academia is different. I mean, and it might be because I didn't work that hard in academia, but I find like academia very much like you set your own pace. You could go really fast if you're really like internally motivated, or you could kind of like not be super stressed all the time. And I was kind of like more on the I wasn't like one of those like did loads of work all the time in academia, but I do find that like at Surgo it's a lot more intense. The workload is pretty intense in Surgo compared to what my workload was like in academia. Ours tend to be kind of you try to do 8 hours, but they sometimes can go on longer to like 9 hours or 10 hours if you've got like a deadline of some sort. And it is, you're working with two quite tight deadlines. I think that it really depends on which company you go to. Some companies are a lot more like, these are the time, you work like 37 hours or 40 hours a week and that's it. But some other places are a bit more.
Yeah, that's good to know. Thanks, Adele. There's lots of nice thank yous and compliments in the chat if you have a chance to look. I think that's probably all we have time for question-wise, but I don't know if anyone has any sort of TARG notices or anything before we go. No.
Yeah, I do have a little one. So TARG's PE event is for the internal staff at UOB is on the 24th of June. And we are still looking for responses to our form that we put in the Slack channel, on the general channel. It's just about, we're making a roller banner for the event and we want to put some quotes on there from TARG members that are basically thanking professional services at UOB. So that could be the admin team, that could be HR, ethics, maintenance, cleaners, anyone who is not an academic. And yeah, there's a form. I'll just put it in the chat, and if everyone could do that, that would be great. Because we are lacking on responses right now.
Thanks, Ellie.
Just a quick.
I added one, but I don't know if other people would find like a couple of examples useful, because I feel like I struggle to know what to say. I don't know if it's just me though.
Yeah, I mean, like any sort of, if HR helped you hire a research assistant that was really good, you could say thank you to that person. Anything really. Thea, have you got any more examples?
Yeah, I think I had one that was about like the data repository team, who were really helpful when I was getting lots of like really specific advice about consent forms and things like that. So yeah, any kind of example, even if it's just really broad, like a general thanks to this group of people, or one specific person, or anything like that.
I think mine was to do with the ethics committee, because I had some potentially sensitive data and I didn't know where to store it, and they really helped me with the legal stuff on that. So that's another example.
No, that's good. That's useful. Thank you. Okay, I think people are leaving now, but yeah, I feel like that's probably a good time to end.
To quickly mention Zoe as well, the IEU barbecue. There's only an hour left to sign up to the IEU barbecue if you want to come, and there will be some TARG people there. So everyone in TARG is invited to that if you want to come.
Is that also next on the 24th? Jasmine, am I making?
Yes, I think so, yeah.
Cool. Thanks. Cool. Have a nice weekend, everyone. Thank you for coming again, Adele. It's great to hear you talk.
Bye. I miss all the events, the IEU events and stuff.
You have to pay for this one though, Adele.
Oh,
Downhill.
it's gone downhill since I've left.
Thanks for speaking to us. See you soon.
Thanks. See you soon. Bye.